It gives me great pleasure to introduce Duke Cameron again to talk about management of the aortic root.
Thank you very much. It's a great pleasure to be invited here and to see so many old friends in one gathering. My charge is to discuss management of the aortic root and acute aortic dissection. And this is a very relevant discussion because, as you know, 3/4 of all aortic dissections involve the ascending aorta. 50% are DeBakey 1s, 25% DeBakey 2s. So 3/4 of all aortic dissections come close to the aortic root, and the decision whether or not to address abnormalities in the root is important. All of you are familiar with the principles of surgery for acute aortic dissection, but it's worth reminding ourselves that the primary one is to prevent pericardial tamponade, and secondarily to address malperfusion. Almost any of the other objectives are secondary and in some sense prophylactic, and these would include addressing aortic regurgitation, excision of the primary tear, and prevention of proximal and distal late aortic complications, usually by trying to obliterate flow through the false channel. And I think all of you are familiar with the basic principles of excising the ascending aorta down to the sinotubular junction, resuspending the aortic valve with the commissures at the proper height, and then reconstructing the dissected sinuses, if they are dissected, with or without the use of glue or felt, and so forth. And this will not really be the subject of the discussion, but rather, when should one intervene on the aortic root? It's very easy to create a slide like this that lists simple indications. These obviously include primary root disease such as Marfan syndrome, Loeys-Dietz syndrome, some cases of bicuspid aortic valve, and when the aortic root is massively dilated, and probably more than 4.5 centimeters at the time of dissection would qualify that. It's also obvious when dissection actually involves the sinus intima, and there are tears within the sinuses, that replacement of the root is mandatory, particularly when all three sinuses are involved or if there's a coronary malperfusion. And then finally, significant valve disease, hemodynamically significant valve disease, would lead one to replace the root. So here are the two extremes, though, that make the point that the extremes are easy, but it's all the gray zone cases in between that lead to the discussion and which really beg for a very tailored, specific approach. But on the left is a patient with a very limited DeBakey 2. He has normal sinuses, a normal aortic valve. No one would question that this patient's aortic root should be left alone. This patient needs a simple tube graft and will do well with what is almost a curative operation. And on the right are three different patients who illustrate very, very abnormal sinuses, such as Marfan syndrome in the upper left, a very badly dissected root with really destroyed sinuses on the right, and a highly diseased aortic valve. All of these patients clearly need an aortic root replacement. But the vast majority of patients we see are somewhere in between, and they make it somewhat difficult to generate guidelines on the management. But there are schools of philosophy that do help us. Stephen Westby, as you know, published a paper 12 years ago extolling the virtues of a very conservative approach that tries, whenever possible, to preserve the valve. Whenever Marfan syndrome is encountered, to replace the sinuses and to use a routine open arch repair using circulatory arrest. And with nearly 100 patients, he had a 5% mortality and only 2 late aortic valve replacements, showing that a very simple approach that's direct and addresses the main current pressing problem is highly successful, at least at midterm. The description of the operations that he performed I put up here mainly just to point out that at the bottom right, he had only 6 root replacements in that entire series and yet generated very, very good midterm results. But as surgeons, we're always asking ourselves, should we be doing more? We know that some of these patients come to reoperation. We've been emboldened by our improving operative results with these operations. So it is natural to ask, is a more aggressive approach to the valve and sinuses advisable in the name of preventing late complications and reoperations? But what are the results of our current conservative approach? How much better do we really need to make things? Now, there are many papers in our literature that address this, but I chose one because it was a good volume of patients. It had been reported recently, and there was very good follow-up out to 15 years. And this was Becker's series from the Netherlands, which appeared 2 years ago in the European Journal. 232 type A aortic dissection patients operated on. The valve was preserved in 157, replaced in 75. And that ratio, by the way, of preserving twice as many valves as replacing is the mark, I think, of a conservative approach. If that's the ratio in your practice, then you're traveling with the herd, and you are practicing conservative root replacement work. And I think that ratio is a surrogate for your conservativeness in approach. Their mortality rate was very, very good, 12.5%. But remarkably, and I think this was one of the most important messages from this paper, is that late survival is still very disappointing in this disease. 50% at 10 years and only 30% at 15 years. And these people were not dying at surgery, they weren't dying early postoperatively. They are dying of a lethal disease that had its most pressing, immediate life-threatening aspect treated successfully by surgery, but they are, most of them, left with a devastated aorta, often hypertension, often renovascular disease, and other problems. And they simply do not do well at the 10 and 15-year mark. Remarkably, regardless of how they managed the root or the valve, the late survival was about the same. So at least if one practices good judgment in deciding whose root to replace, the results at 15 years were about the same. And freedom from reintervention on the aortic root was 86% at 10 years. Now that's very good. There are very few heart operations that we do that work very well, and 86% of people out to 10 years. So is it really worth exposing more patients to bigger operations and root replacements to address that 14% at 10 years who needed a second operation, most of them who also do well at a second operation? And interestingly, if we are trying to develop a selected approach in identifying patients who are at the greatest risk for reoperation, in their series, only preoperative severe aortic regurgitation accurately predicted who ultimately would need a late aortic valve replacement. Their experience has been like much of ours in that we've seen more and more patients. Our annual volumes of these cases has grown, and the hospital and operative mortality has steadily decreased, and as I said, a very admirable 12% now in their current era. Their freedom from valve reoperation, as I said, was 86%. It was even higher if you replace the valve with a mechanical valve, but no one is suggesting that be done. There are too many problems related to anticoagulation and valve prostheses. But their valve-preserved patients, those who just had the conventional operation, actually had a better freedom from reintervention than those who had bioprostheses placed or bioprosthetic roots. Again, supporting the conservative approach, which works so well for so many patients. And the last graph just shows that preoperative severe AR is a risk factor. And in fact, other papers have also demonstrated other risk factors. These are all the things you need to keep in the back of your mind that might lower your threshold for replacing the root. Not absolute indications, but relative indications. Coronary malperfusion, severe preoperative AR, aortic valve preservation, well, that's sort of self-fulfilling and probably shouldn't even be on that list. The use of GRF glue and the remodeling operation as opposed to the reimplantation if one does a valve-sparing operation. I'm not going to go into this slide because Dr. Tremarchi went into this, but I had included it because it is one of the few studies that tries to compare the valve preservation operation with replacement. But it is the IRAD study, or database. It is an operative registry. The limited follow-up of only 3 years really doesn't allow you to make predictions over whether replacement or repair was the better strategy in the long run. But I do want to point out that, again, the ratio of 2 to 1, 2 conventional operations to 1 root replacement was the case in the IRAD study. So I think we're developing a consensus. That's probably about the right ratio in one's practice. The patients who did have root replacements were younger, they had bigger aortas, more Marfan syndrome, and were sicker. But I think all we can say is, in the hands of experienced centers and good surgeons, the additional risk of replacing the root is still small, but that's a big if. And it's not clear that the benefit is extended to all. I similarly noted this trend in root replacement and how different it is in Europe and the United States. I really don't know what to say about this, except that the differences are actually not that great. And there was an initial enthusiasm in the middle of the series in Europe for full root replacement, but that it's actually coming back down. I would argue the curves are approaching. Now finally, what's the role of a valve-sparing aortic root replacement? If the patient has dissected sinuses but a normal aortic valve and is young, should we be thinking about valve-sparing surgery on that? Well, we have to look to the Hanover series because they clearly have the largest experience in the world with valve-sparing root in the setting of an acute aortic dissection. They had 53 patients when the total valve-sparing root series was at 284. Their early mortality was low, and it was the same as the patients who had valve-sparing surgery without aortic dissection, and similar late results. So it's an operation that can be done in that setting. There's nothing anatomic about an acute aortic dissection that precludes a valve-sparing aortic root replacement. But their results were good because of the caveat, which they made very clear, that this is an operation that requires a tremendous experience with to be able to do it expeditiously and safely and not add substantial morbidity to a root replacement, and that patient selection is absolutely key. It doesn't make sense to do this operation in older patients. It may make sense in younger patients, but they have to be younger patients who are not in the midst of malperfusion or where you're worried about other organ systems. If you do a valve-sparing operation, it should be a reimplantation operation. Again, anatomically, you can do a remodeling, but bleeding is the major issue in these patients, and there's no question that the reimplantation operation has much less bleeding. And in those patients who have connective tissue disorders, the annular stabilization will also be important in the long run. Finally, the part that no one really talks about in any detail is the surgeon. What experience he or she brings to the operating room, what environment is he working in? And remember, the aim of this effort is to produce a survivor, not a hero. The dissection surgery, unfortunately, is often done off hours by the most junior or inexperienced surgeon in the team. That, I think, is a practice that needs to be reexamined throughout the world. In the United States, because of the great distances between centers, most aortic dissection surgery is done at low centers by people who do not have a lot of aortic experience, and I don't see how that's going to change. So I think our guidelines for the management of the root in acute dissection has to take this in mind. And remember that even experienced dissection surgeons throughout the world rarely do more than 10 cases a year of this. And most US surgeons do only 1 or possibly 2 root replacements a year, much less in the setting of an acute dissection. So in summary, most patients are well served by a simple valve resuspension and a supracoronary tube graft with an open distal anastomosis. Late root reoperations are infrequent, probably on the order of 15% in most series. But you should consider root replacement if there's significant sinus disease, a very dilated aorta, extensive dissection and intimal tears, Marfan syndrome, Loeys-Dietz syndrome, and perhaps some young patients with bicuspid aortic valve. And then obviously with intrinsic valve disease, the decision is often made for you. Valve-sparing operations may be appropriate in selected young patients, but really only in the hands of experienced root surgeons. And I finish respectfully with Bob Bonser's comment about valve-sparing aortic root replacement in the setting of acute dissection, the right operation at the wrong time. Thank you.